Okay, everybody, let's go ahead and get started with the last presentation for the day. Dr. Mutzeiger is going to present on sedative hypnotics, their use and misuse. This is another really great presentation with a lot of good tips that'll help you to be more effective. Okay, so with that, help me welcome Dr. John Mutzeiger again. Thanks.
Thank y'all. Good afternoon. I'm ready for my afternoon nap, I tell you. Sedative hypnotics, their use and misuse. Now, this is from a study of 2.9 million initiates, first illicit drugs, okay? Marijuana, 65%. Pain relievers, 17%. Tranquilizers, 4.1. Stimulants, 3.6. Some small numbers. So it's not that much on first time. However, they did a study on 12th graders and who had used what in the last 30 days. And 68% had drunk alcohol. And the following figures: tranquilizers is 7.7%, opioids 11.1%. So this is where we are. I'm going to start with this is on sedative hypnotics, so that barbiturates will cover first. They were synthesized by the Bayer Corporation's founder, von Bayer, in 1864. 1903, barbitol was synthesized. 1912, phenobarbital. So they're old drugs, over 100 years old. And these were the original drugs of choice. Marilyn Monroe died from a barbiturate and alcohol overdosage. James Mansfield was decapitated because she ran into a train under the influence of barbiturates. They were what the celebrities used to die from. The benzos came around in the 1950s. Dr. Leo Sternbach found Librium, or chlordiazepoxide. These are some pictures of the yellow jackets and red balls, as they used to be called. Seconal and Imutol, phenobarbital, Mebarol. What types do we have? We have ultra short, short-acting, intermediate, and long-acting. Thiopental for induction of anesthesia. Methotrexate didn't use that much. We use phenobarbital for seizures. Amobarbital is a hypnotic. Intermediate, we use butalbital for headaches and pain. Seizures sometimes. Long-acting, we get to the phenobarbital, the mephobarbital, sedation, and seizures. They're lipid soluble. What does lipid soluble mean? It goes where? Direct to the brain, because that's, in essence, fat type tissue. Okay? It's excreted through the hepatic metabolism and then renal excretion. You can get rid of it through alkalinization of the urine, and half-lives are increased in pregnancy in patients with chronic liver disease. So you never want to give phenobarbital to people with chronic liver disease, because you never know what their blood level is going to be. They depress respiratory drive, and the hepatic metabolism is responsible for tolerance because the enzymes get induced and it starts metabolizing the medicine out of the system extremely fast. Benzos is that we went back to, but then Valium in 1963. And the last part of the 20th century was the age of anxiety. Mother's Little Helper in the Beatles song, as if you remember back. Valium. These were used for many uses: sedation, hypnotics, anxiolytics, and amnestics. How do they work? Both the barbiturates and the benzos, and even the non-benzodiazepines, We call them non-benzodiazepines, even though they work the same way. Are modulated the GABA alpha receptor. It's a ligand-gated chlorine channel. When stimulated, there's a fast postsynaptic inhibitory potential. The receptor changes in space. In other words, it activates. The GABA comes into the GABA channel, reduces the probability of an action potential, and you are relaxed. No anxiety. This is a G protein coupled receptor, the GABA beta, that acts as a dimer, and it increases permeability of the potassium and decreases calcium conductance. But everything's really going on with the GABA alpha. For barbiturates, there's a positive modification via allosteric mechanism that increases the effect. In other words, it is a direct GABA alpha agonist and prolongs the opening of the chloride channel at the beta 2 and beta 3 subunits. Here's a picture looking down on the GABA receptor. This is where GABA fits. This is where benzodiazepine fits, between the alpha 1 and the gamma 2. The GABA is between the alpha 1 and beta 2, alpha 1 and beta 2. Here's a picture looking at it through a cross section. Once again, benzos, GABA here. And remember that benzo makes it more likely that the GABA is going to have an effect. And of course, there's through the membrane which it allows. These are other schematics from through it and on the side. And this is a schematic showing that this is a high affinity GABA receptor, and it can't quite get to there because GABA modulin is in the way, but you get a little benzodiazepine in there and it opens right up and the GABA gets in there. The non-benzodiazepines are Ambien, Sonata, Lunesta. Those are the prominent ones. And they act through overlapping binding sites at the alpha and beta. And these drugs inhibit Dalmane, which is just thrown in there. The peak of use was in the 1975. 1 out of 10 prescriptions. Kind of like Norco today. They're prescribed mainly for anxiety and insomnia. They're relatively safe with rare overdoses, but they are addicting and they are taken with other drugs. The clinical uses: anxiety, generalized anxiety disorder, panic disorder, phobias, PTSD, obsessive compulsive disorder, insomnia, and anxiety associated with cardiovascular, GI, or somatoform disorders. Notice I've yet to say for how long, and that's going to be the sticking point. It's also used for convulsive disorders, status epilepticus, neonatal seizure disorders, preeclampsia, tetanus, adjuncts, and amnestics before surgery, spastic disorders, and voluntary movement disorders. They have a lot of reasons to use them. We use them for detoxification from alcohol and other benzodiazepines. We use them for agitation of anxiety, acute mania, acute psychosis. They're great for people in acute spice withdrawal. It's about the only thing that settles them down. Impulse control disorders, catatonia, mutism. There are other adjunctive uses for diagnostic and therapeutic procedures. What about toxicity and side effects? They replace barbiturates. There's less respiratory depression and are rarely lethal by themselves. However, you get drowsiness, lethargy, ataxia. That's the guy who walks down the hall and they just can't keep it in a straight row. And there's no urine in their drug screen. Seizures, if abruptly discontinued, hypotonia, dysarthria, dizziness, and even hyperreactivity. And paradoxical hyperreactivity happens all the time. People take a couple of Xanax and they get in a fight in a bar, especially with a glass of wine, and then they end up in the legal system. Now, let's talk about the high potencies: Halcyon, Ativan, and Xanax. Then there are the long half-lives: Klonopin, Librium, Transine, Valium, and Dalmane. We don't use Dalmane anymore because it accumulates in the systems of people in the geriatric population, and they tend not to wake up. Short half-life: Serax and Restoril. Now, why do people abuse them? Hedonic. It feels good. You don't worry about stuff. You can go with the flow. Tolerance. This is a drug that works, but the longer you take it, the more you have to take. Now, why is that? It affects the messenger RNA at the GABA subunit, and if you're making less of it, you have less receptors, so you're going to need more medicine to get the same effect. And so people escalate their dose because they want the same effect as beginning. Okay? Now, benzos with rapid onset have the greatest risk of that type of abuse. Ativan, Xanax. Okay, tolerance causes people to escalate the dose, and withdrawal symptoms appear upon decreasing dosage or discontinuation. Tolerance develops as decreased responsiveness to GABA alpha receptors. And as I said about the messenger RNA, so that you down-regulate your receptors. You don't have as many receptors, you need more drug. The glutamatergic system may also play a role in the withdrawal syndrome by turning it up. They occupy an intermediate position on abuse liability. Dr. Williams showed you the thing, and they're kind of right in the middle. Barbiturates and methaqualone had greater risk. We don't have methaqualone in our society anymore. We don't have the date rape drug or Hypnol. But we still have Milltown and Equinil. You know what form it comes in now? Soma. Soma gets converted in the liver to Equinil. That's why people say it's a great muscle relaxant. Well, it is, because it's a tranquilizer. You don't care about anything. And of course, we use Valium for muscle relaxants. And it's kind of frightening when you get somebody on benzos and Soma and drinking and have to detox them. When used alone, they're low risk. And when used with other types of medicines, they act synergistically with other CNS depressants, sedating antidepressants, neuroleptics, anticonvulsants, antihistamines, and alcohol, with and without opiates. Hence, we see people die. They don't wake up because they took it with an opioid, or they took it with antihistamines, or they drank some alcohol. What do we see when we get a drug interaction or toxicity? Psychomotor retardation, drowsiness, poor concentration, ataxia, dysarthria, motor incoordination, muscle weakness, vertigo, and mental confusion. Memory impairment is a big one. They don't remember what they do or what they said. They can induce anterior grade amnesia, which makes them a great drug for doing GI procedures or even doing dentistry. And nobody remembers what happens. Okay? This appears separate from sedation as an effect. They're not linked. Paradoxical disinhibition, we talked about that before. It may, in rare occurrences, result in attacks of rage or violence or other antisocial behaviors, more common in children and the elderly. There's also depression and emotional blunting. There's an association between benzo use and depression and depressive symptoms, and in some cases, even the emergence of suicidal ideation. In my work, I get a lot of people, they're depressed, but my Xanax makes me feel better. It does, but makes you more depressed too. So a lot of people will take these thinking it's helping their depression, and if I've heard it once, I've heard it 150 times. I take Xanax for depression. I know y'all have heard that too. Well, it doesn't treat depression. Now, dependence may appear as early withdrawal or protracted withdrawal. Approximately 80% of people who abuse benzos do it with polydrug abuse. It's rarely alone, it's usually with opioids, and 3 to 41% alcohol. There's an increased risk of abuse if you're using a high potency. Remember Ativan and Halcyon, short duration of action, high purity, water solubility, or high volatility. Get an overdose. What does it look like? Dizziness, confusion, drowsing, just like toxicity, anxiety, and agitation. This is an interesting slide. I want you to notice 50 to 54, 55 to 59, and 60 to 64. These are the percent using in the last month. So what I want you to take away is people in the 50 to 65 range, drug use. It's not your 25-year-old, it's not your 30-year-old. It may be your 65-year-old, okay? Addiction does not respect sex, culture, social standing, or anything. It's an equal opportunity disease. And I'll reiterate what Scott said. These are some of the most wonderful people in the world. The reason they take these medicines is because they are dysphoric. They don't feel good. Now, why don't they feel good? I think it's genetically determined. And they're very sensitive. Therefore, they're always looking for a way to feel better. But they've never learned to find a way through a recovery program to get better. And they turn into just such wonderful people. Great example is Gerald Ford's wife. You know, she had breast cancer and used pain pills and benzos because of the pain of having cancer until she became addicted. Did not make her a lesser person. Physical exam findings, nystagmus. If somebody's got nystagmus, you've got to think about benzos. If they're hallucinating, well, they don't teach you this very often, but hallucinations are very prevalent with benzos. Slurred speech, ataxia, coma, hypotonia, weakness, amnesia, and the others we talked about previously. We diagnose it through immunoassay screening, ABGs, chest x-ray, pregnancy tests, and the rest. It's the typical ER. It increases with age, so your suspicion should go up with age. Women are twice as likely to get a prescription than men. You know, we're supposed to be strong and all that. 1/4 of all prescriptions for benzos are for long-acting, but men are more likely to abuse them with opioids. Withdrawal syndromes, insomnia. I can't sleep, doc. Let's give them something to make them sleep. Just treating the same disease. Stomach problems, withdrawal, they throw up repeatedly, bless their hearts. You know, the stomach it complains. Tremors, agitation, fearfulness, muscle spasms. And if you want to know, besides the tremors, if it's a benzo withdrawal, look at the eyes, because they'll be that big around. And if the patient tells you they feel like something bad's going to happen, they're getting ready to have a seizure, because they get the premonition that they're going to have a seizure. Less likely are irritability, depersonalization, derealization, hypersensitivity to stimuli, suicidal behavior, depression, psychosis, DTs, seizures. If anybody wants to read the primary book on benzo withdrawal, it was called Dancing as Fast as I Can. It was written in the 70s about a woman who detoxed herself off of Valium. And it's quite descriptive. And she didn't use anything for detox, and it's just to make your skin crawl. Do not give it to people with respiratory depression, myasthenia gravis, sleep apnea, bronchitis, COPD. How many people you see with COPD taking benzos or non-benzodiazepines? Lots. Personality disorders, depression, pregnancy, elderly. It's pretty much a contraindication. Now let's talk about the pharmacokinetics, and this is where most physicians don't know their benzos. Half-life, speed of onset. Xanax. Half-life is 12 to 15 hours for the first active metabolite. It's an intermediate onset, but there are active metabolites that will last up to a year. Knew a patient who was an expert on magnetic pulse, worked for the government in Virginia, and he ended up being a benzo Xanax addict. And well into his 6 to 9 months recovery, you could watch him go to a withdrawal when something was washing out of his system 6 to 9 months later. It's really impressive. Librium is 10 to 30 hours, it's intermediate. Klonopin 18 to 50 and slow, and it has other active metabolites. Valium is 20 to 80, it's fast onset. Ativan is 10 to 20 hours half-life, and it's intermediate. The biggest problem I see with Ativan, people come into the ER, and the ER doctor gives them Ativan for withdrawal, Ativan for withdrawal, Ativan for withdrawal. It's intermediate onset. And they'll give them enough Ativan where they quit breathing, so they don't realize they've given them too much when it all takes effect. So I tell people in DTs and delirium, diazepam is the drug of choice, because whatever you give them, you're going to see. And if you don't give it more than 5 milligrams every 2 minutes, you won't get into trouble. Serax is slow, Prazepam is slow. They're pretty much not in our country anymore. They interact with the cytochrome P450 enzymes with other drugs, and drugs metabolized through glucuronidation in excretion, oral contraceptives, some antibiotics, antidepressants, antifungals, inhibit these enzymes, and so the levels will go up. Tegretol and Dilantin accelerates them because it induces them getting cleared out of the body. So careful with these. Prozac, are they taking Tagamet over the counter, which anybody can take? Macrolide antibiotics and the antifungals. Now, interesting, I was talking to Scott about this at lunch. The British Medical Journal in 2014 published a retrograde analysis. And I'm just as abhorrent of retrograde analysis as you are. Because nothing's controlled. However, my personal experience has shown that benzos and benzos with alcohols are some of the most destructive chemicals to brain tissue. It may permanently affect the messenger RNA so that they don't have as many receptors. They're much more anxious. They're much more prone to seizures. And they may be prone to Alzheimer's. There is a stronger association reinforcing the suspicion that there might be a positive association, or it just might be a marker. Unwarranted long-term use of these drugs should be considered as a public health concern. He found that significantly associated, if you take them any time in your life, there's about a 1.52 increase. More than 6 months, 1.85. And if you take the Klonopin or Valium, it's 1.72. This was just a case control, not a randomized control. So, what should be our guidelines for benzodiazepines in our practice? They should be contraindicated here. Pregnancy, substance abuse, including alcohol. Just because they're an alcoholic, don't put them on a benzodiazepine. It's just a drink in a pill form. Does the same thing. It'll get rid of their craving until they want more, when it'll eventually happen because they'll get tolerant. Medical and health problems that may be aggravated, remember those, including myasthenia gravis. And patients being treated with opioids for chronic pain or replacement therapy for narcotic addiction. I see hundreds of people who come to me on Suboxone and Xanax. No, no, no. You should not do it. You might get away with it, then you might not. Indications for short-term treatment with benzos. 2 to 6 weeks, anxiety disorders, as an adjunct until the primary drugs you're going to use take effect, which takes about 6 weeks. I detox people from benzos all the time. I put them on the combo I talked about earlier, Lexapro, Celexa, or Paxil, plus Elavil or Pamelor, or one of the other tricyclics in small doses. And it works. You may need short-term muscle relaxants. They might have some insomnia. You can use that. And urgent treatment of psychosis and agitation, alcohol and benzo detox, seizures and sedation. That's what we use them for. If they're chronically, terminally ill, not going to live 6 months, you can use them longer. Certain neurological disorders, cerebral palsy, and some of the inherited muscle disorders, you can use them, especially in severely handicapped, because it might be the only thing that allows them certain types of movement. How should we taper them? It's a long-term project on the outpatient. Do I recommend outpatient tapering? No. I've had 1 or 2 successes in 20 years. Most of the time they can't. They will not get off of it. But if you're going to do it in the hospital or outpatient, you decrease every two weeks 10% of the dose. So if they're on 6 milligrams of Xanax, you decrease it 0.5 milligram every 2 weeks. Okay? That's about as fast as you can do it. You can switch it to an equivalent dose of a long-acting benzo or phenobarbital and then taper off. That's what I usually do. I've yet to find anybody who really likes to take Transane. It just doesn't do anything for anybody. Counseling should be available. You might need to use Tegretol, etc., to facilitate a more rapid withdrawal. Special considerations. Don't taper Xanax too quick because you have a higher incidence of withdrawal seizures. Patients with other addiction problems or high doses, taking other opiates will be more difficult to withdraw. Consider a consult. As patients age, they become more sensitive to the same dose of benzodiazepines. There is a risk to operating machinery even with stable doses. Somebody has a wreck taking benzos that you prescribed and you did not prohibit operating heavy equipment or cars, you may be in trouble. Stable doses do not prevent difficulties and cause risk with operating machinery. This is the equivalence table. Know this. Now, how many people have ever written a prescription for 2 milligrams of Klonopin 3 times a day? I have at one time or another. You know, I see it all the time. Let's see. A Valium 10 milligrams is equal to a half a milligram of Klonopin. So if you write 2 milligrams of Klonopin, you're writing 40 milligrams of Valium 3 times a day. That's a pretty big dose. And I bet you your drug rep never told you that. Librium is about 25 milligrams to a half. Xanax, a half, is equal to a half. So Xanax and Klonopin about, and there are lots of people on Xanax 2 milligrams 3 times a day. And some of the people in my practice come in taking 5, 6, and 7 at a time when they want to come down off of methamphetamines. Ativan is 1 milligram is equal to a half. Restoril 20 is equal to a half. Ambien 20 milligrams to a half. Sonata 20 milligrams. And Lunesta 3 milligrams is equal to a half a milligram of Xanax or 10 milligrams of Valium. And most of us will not give somebody Valium 10 milligrams to go to sleep. Now, this is my bibliography. Good old Goodman and Gilman, Substance Abuse and Principles of Addiction. University of Texas Health Center at San Antonio. They have a great drug information service. Questions?
I have a question.
Yes, ma'am.
About the replacement therapy. Like,
Mm-hmm.
does it just depend how long they stay on it?
Like I said, you can decrease it about 10% every 2 weeks. So in the hospital, if I figure somebody's taking 10 milligrams of Xanax today, I'm going to go put them on probably anywhere from 15 to 22.5 milligrams of Transine every 6 hours. And the first 24 hours, I'll figure out if I need to shorten the dosage span to every 4. And as soon as the patient can sleep on my replacement amount, I know I've got equivalence. Okay? And then the next day, I love Transine because you can go from 22.5 to 18.75. Just a little decrease. And then down to 15, 11, a quarter, et cetera, et cetera. So it's a great medicine to use. Transine is every 6 hours. I see internists all the time write Transine every 12 hours for withdrawal. It's a 6-hour withdrawal drug. Or they write Ativan 1 milligram every 8 hours. When somebody's withdrawing, you've got to cover them according to the half-life of the drug. So Ativan is every 6, Transine's every 6. I never use Klonopin or Xanax. I will use Librium, and it's every 6. Any other questions?
I'm so glad you brought that up about alcohol and Valium. To be honest, I mean, it just gets worse and worse. The alcohol is 24 hours a day, it's everywhere. And you know, people ask you for Valium, so I'm really glad you brought it out. I
Yeah.
didn't really see the importance of it that much.
Yeah. Yes, sir.
So when you're going to withdraw somebody from Xanax, you recommend inpatient withdrawal for the whole period of time?
The whole period of time. I've been unsuccessful outpatient. Yes, sir.
This was close to home. I've got a 94-year-old mother that's been in assisted living here in Hattiesburg since Katrina, and she fractured her hip 6 weeks ago. And she's been on Valium or some. She's been through all of them. Other physicians, groupings, and physicians. 94.
Well, you know, that's a,
We've been through, looking back on the history, she's been on Xerax, you know, the whole gamut. When she was in the hospital and in rehab, she was agitated mainly because she was a strange, circumstance more than anything. They had her on Xanax, but because she had her days and nights and stuff, they had actually increased her Xanax from a half of a 2.25 in the morning and a 0.25 at night. They had just bumped her up to 0.25 twice a day. So I picked her up. I wasn't aware of that, but I knew she was more agitated. So, called the hospital and stuff here and realized what had happened. So just try I could go back. Because she had only been on that dose maybe the last 2 weeks.
okay.
Tried to put her back on the original dose of 0.125, half of a 2.5 in the morning, and a 0.2 agitation, hallucinations, full bit.
Remember
Back on the 0.2 twice a day. At her age and her longevity, she seems reasonably controlled, but it's twice a day.
Are you going to change somebody at 94 years old? I don't think, and this is part of what I was
I
saying.
figure it is, have had enough of a boost to need to increase back up. And
Yeah.
I'm about day 3 right now.
Yeah.
That's why I'm half asleep now. I've been up for the last 2 nights.
Yeah. Well, the question is, I think, what do you do in these circumstances, in chronic circumstances? And I'll give you some from my, I've had people on Xanax, I've gotten off, and 8 weeks out of treatment, they have a seizure. I've got to put them on phenobarbital. Some of them, it's been years and they're still on phenobarbital because their brains cannot function without benzodiazepines. And if your mother's been on benzodiazepines 30 years, hers may not function without it. 50 years, right. So, of course, you've got to continue it at that point. But the fact is, psychiatrists are very eager to write this because what do they have in their armamentarium that works within 2 weeks? Benzos. And then you got to get them off of it. And it takes time. They did a study on the West Coast. They gave 0.5 milligram to Xanax at bedtime. I think it was to 100 people. And they discontinued it at 30 days. 50% of the people, and these were all treatment naive benzo patients, 50% of them had withdrawal. So Xanax causes dependence very quickly. It's the worst. And I think Klonopin does too. Yes, sir.
For your inpatient withdrawals, what are your criteria for giving up and calling anesthesia?
For giving up,
Giving up on your withdrawal and calling anesthesia for
status epilepticus.
status epilepticus.
Yeah. Yeah. And if I have one seizure, It's usually because I don't have enough benzos on board. But status epilepticus means you're going to have to put them down.
If somebody were 35 and not 95,
Yeah,
and they were on, given the limited number, they're not on 2 milligram bars, as they call it.
yeah. And there's a 3.5 milligram you can get from Canada now.
That's great. I'm glad I retired.
And it's long acting though.
Oh, yeah. Well, is it the same where they really get the regular dose in the morning and the other in the afternoon?
Yeah.
So it's really not time relief
No.
and this mixed market.
Yeah. The question is, what do you do with younger people? I think, you know, it involves at times family. It sometimes involves their job
And their insurance.
and their insurance.
Hospital, yeah.
Oh, you said the banned word, insurance. I'm very well versed in the American Society of Addiction Medicine criteria for detoxification, book like that. And I deal with insurance companies whose only job is to save them money. Okay? You got 3 days to get somebody off of something. Well, it's impossible. Because we end up eating it because you can't discharge them. There's a Medicaid here in this state now that it's now, what do you call it? Managed care Medicaid. And I had somebody taking about 8 milligrams of Xanax. It wouldn't give me any days. Well, anybody who knows anything knows that you can't get somebody off of Xanax in less than really 4 or 5 days. You know, and I asked for their criteria because I'd read it on the website. They sent me a list of all these publications. One of them was the American Psychiatry Association criteria for admission. And nowhere in that criteria was there anything saying that benzodiazepines needed detoxification. And that was as recent as 1997. So that organization doesn't look at benzos as we look at benzos.
If you're dealing with a young, salvageable person, and you're going to take somebody, you know, 2 or 3 a day of Xanax, not the guy that's strictly taking this to get off in there, or let them off, you know,
Yeah.
whatever.
And
What's your longer acting drug of choice to use to convert? say,
Transine.
Which one?
Transine. Now, why do I use Transine? Transine, the question is, what do you use for detoxification that's in the long-acting category? Transine is predictable. It's long-acting, but it also comes out of the system slowly, and it builds up slowly. You don't want something that's going to build up quickly, because then you overdose them, and you don't want something that dissipates very quickly because they'll go into withdrawal again. And I've used Transine for almost 30 years because the addictionologist taught me how.
3 years ago, when the second time I took this course, I keep remembering this course for some reason. After taking it years got with that time, I went and read, and all the conversions 3 years ago, people were using the model that I was seeing references to. They were using the second dose, the 9-time dose, values, almost exclusively in everyone I looked at.
No, I don't know why they are, because you know, if you use Transine, you need something to help them go to sleep. Give them a milligram of Ativan, because it goes in and it goes out, and it doesn't hang around. Yeah, that's the best way. You've got to be real careful mixing benzodiazepines because you don't know what's going to be in there. For the same reason, I don't advocate ever using methadone. and you have to be careful with drugs with really weird pharmacokinetics.
Can you emphasize again, blew my mind when you said the Alzheimer's and combination of valium and alcohol.
Yeah.
You know, it's being used so much now, Alzheimer's, we all fear it. We're 100% in this room.
Yeah.
Don't want to lose any memory.
Well, I've been involved with the recovery community in my area for well over 20 years. And you can tell a benzodiazepine recovered person because they usually have some type of memory impairment. I have seen that. They don't, it's opioids don't do permanent damage, and I'll agree with the anesthesiologist on that. They're kind of clean. Alcohol is probably the worst. Methamphetamine and cocaine next. But the benzos, when people get addicted to them, it affects their thinking, you know. And if they drank and took them, they don't think as well, and they get well really slow. It's a nasty drug. So I enjoyed lecturing to y'all today. You've been a good audience. Thank you very much.